So again, welcome to today's session on PMTCT intrapartum care. I hope that it will be a value-adding session to all of us. So just to remind everyone that I am part of the Aqua Training School, and we are an accredited school. We offer both accredited and non-accredited courses. What you will love about us is that we are just here to serve you. So hopefully, you know, one day you join us and do some of the training programs that we have. If you find today's session to be a bit above your head, contact us, you know, on our email, which I will share towards the end, to do this free HIV course on HIV management, because that will really help you to understand most of the concepts that we are discussing. So for today, just to say you are welcomed, and today's topic is the management of HIV during labor and delivery. And then at the end, we will have some time for questions and answers. Just to remind ourselves that today we are discussing, you know, labor and delivery. However, the PMTCT program starts way before women are even or even fall pregnant. Our focus is primary HIV infection in women, specifically focusing on those of childbearing age, and also increasing access to family planning interventions so that all pregnancies where possible are actually planned pregnancies. Last week, we discussed the antenatal care to say once a woman falls pregnant, what is it that we need to do? And especially if they also test HIV positive, what are some of the things that we would need to do? So today's session is focusing on the key interventions and processes we need to get right when we manage women in labor and delivery. And then next week, it will be the third and last session on PMTCT, where we would then specifically discuss the postnatal care. So what happens beyond delivery in terms of the follow-up and support that our women will need. So that is where we are. Just to say that in terms of labor and delivery, it is actually a beautiful time, you know, because we've been cooking and putting, you know, all the mixtures in the oven, and now it's time for the delivery, you know, of the baby, beautiful baby. And we've got mainly two objectives during labor and delivery. The first one is the safe delivery for the mother and then also for the infant. So make sure that as you manage labor and delivery, that we pay attention to both the needs of the mother and the infant, but it has to be safe. So the safety of both the mother and the child are very important. And then you can see the second objective is to prevent mother-to-child HIV transmission during labor. So the HIV prevention component is not the first priority. The first priority is to make sure that both the mother and the baby at the end, they are alive and they are well. And we should not, as we discuss PMTCT, it should not be separated from the general obstetric care that might need to be given to both the mother and the child. So today's case study is a continuation. If you remember last week, we discussed Leah in detail. So I'll present her as a 34-year-old mom or female who presents. Today she presents for labor in your delivery ward, right? She booked early when she was estimated to be 10 weeks pregnant. So this is what we want. We want women within the PMTCT program to present early so that we have enough time to intervene. During that visit, she tested HIV positive and was started on ART the same day, right? Which was tenofovir, lamivudine, and dolutegravir. We can argue whether efavirenz and so on, but we have confidence that dolutegravir was the best drug option for her. She expressed, you know, counseling and testing and the fact that, you know, she needed more information, hence she was tested. She was then seen again 3 months after starting ART. So it means at this date, she started ART, and 3 months later, she was seen. Her creatinine, her kidneys were okay. However, her viral load, 3 months after starting ARVs, was actually high at 9,000. So that is, a viral load of concern. She was then provided with enhanced adherence counseling, which we discussed last week, and the viral load was repeated again in 30 days, which is a month. And unfortunately, that viral load came back to be at 3,000. However, today we say she never returned to review the second viral load results. So when we saw her and did adherence counseling and repeated the viral load, that was the last time we saw her. And today she's presenting in labor for delivery with a history of 2 consecutive viral loads that are high. So, there's a question to say, so what are the steps, that need to be taken for this mother during, this delivery? What do you think are the things that we might need to do? So this is a very important case. However, it's a common occurrence where mothers last seen with high viral loads present for labor, and it's a very important discussion point for us today. Let me see if I have a question for you, which I want you to answer at this point in time. Yes, so it's a different question, but I'm hoping that but let's maybe put the question for later. We will come back to our poll later on. So let's continue. So in terms of what is a priority in labor, what are our priorities? The first one is we need to ensure that we are able to provide safe obstetric care as per the local, guidelines. And so far, we are guided by the ESMO and many other maternity guidelines in the country. So that is the priority. So if she comes in and she's got antepartum hemorrhage, we need to respond to that. If she's got the hypertension and she's got fits, we need that becomes the first priority, not necessarily HIV at that point in time. And as soon as we have addressed those specific emergencies, then we are able to respond to the HIV-related needs, of that mother. So in terms of the management of HIV in labor, HIV testing is very important. So if a woman presents and she has never been tested, we have to offer that. And then if she was tested negative previously, we want to confirm that she was negative and still offer the test, in labor. We want to ensure that women who are unbooked, right? Women who are unbooked, we are seeing them for the first time in labor, or they test positive for the first time in labor, that we are able to provide appropriate ART prophylaxis, start them on ARVs as soon as possible, hopefully in the next 24 hours. As soon as they are stable, we are able to explain to them about the treatment. We need to do a delivery viral load. So all women who are HIV positive, irrespective of when they started ART, we need to make sure that we do that delivery viral load. A birth PCR, so when the child is born, we need to test the child. So all HIV exposed infants or babies, we need to then do a PCR at that point in time and also initiate appropriate prophylaxis. And we say appropriate prophylaxis because we have 2 kinds of prophylaxis. We've got the low risk and high risk prophylaxis, and this is based on our history taking when we start to engage with the mother, right? So again, in labor, you will get 3 kinds of women. You get a lady who comes in and she's in labor. Previously, she was tested and she was tested to be HIV negative, right? We need to repeat the HIV test in labor, regardless of when the last one was done. So this is a key, intervention in terms of HIV negative women. Where a woman presents, her HIV status is unknown. That means she was never tested before during the antenatal process. We need to then provide counseling and provide the test, right? So it means all HIV status unknowns, and those who are HIV negative in labor, we need to provide the HIV test. And then if she's HIV positive and on ART, we then continue the ARVs, as prescribed. So we do not give, any other intervention at that point in time. So it's very important that even in the labor wards or delivery centers, that we are able to provide what we call PICT, previously provider-initiated HIV testing, and it should be presented to all women who present in the labor ward, especially those who are not known to be positive or those who were tested negative before. This includes any child who is born before arriving at the hospital. HIV testing has to be provided. If both the mother, the woman and the husband are there, we should provide to both of them. Women who refuse to be tested, we need to provide counseling and retest during labor or even next time when we see them. If a woman tests HIV positive at any stage, right, we need to encourage testing of other children and even, their sexual partners. That's very important. And if a woman has a, you do an HIV test, the first test is positive, the next test is negative, and we cannot conclude the HIV status of the mother, right? And this is in labor. We therefore need to treat the child as a high-risk HIV, exposed infant until we can confirm the HIV status of the mother. So this is very, very crucial and important, that where we are unable to confirm the HIV status of the mother for whatever reason, the child should therefore be treated as high risk until we are able to confirm that the mother is negative, and so on, and make sure that every communication and results are documented in the maternity record and the road to health booklet in terms of the child, right? So the first priority, like I said, is the response in terms of the obstetric care. The second one is the issue of ensuring that HIV testing is provided in labor, because it is an entry point to key interventions where, without knowing the HIV status, it becomes very difficult for us to know how to intervene. So antiretrovirals are very important, and they are our key interventions for reducing maternal viral load and ensuring that the child is not exposed to high viral loads at any given time. So the key message is that pregnant women who come into labor and they are already on ARVs, they should continue their ARVs as per the usual schedule. So if she takes them 8 o'clock in the morning, she continues as such. If it's in the evening, she continues as such. Now, we have a particular group of women who are going to be newly diagnosed. Remember, we just said every woman who has negative previously or with an unknown HIV status must be given an HIV test. So some women, you'll give them the HIV test and they will test positive, right? And some women, they tell you, yes, I already know, I've tested, I'm positive, but they're not on ARV. So how do you manage those kinds of patients? So the first thing is that you will give a stat single dose combination tablet, so TLD. So the same drug, which is our standard first line regimen. Remember, at this point in time, you are not giving it as a long-term ARVs. You are now intervening because the mother is in labor. She's got because she just tested positive, or she knows that she's positive but not on ART. We know that her viral load is high, so we want to intervene and protect the child during the birthing process. So how do we deal with this? We no longer give, previously we used to give Truvada and AZT3 hourly. That is an old protocol. It is no longer practiced. So we will give ARVs, triple drug therapy, the combination of tenofovir, lamivudine, and dolutegravir, and a single dose nevirapine as a state dose. We give and say state dose. We are intervening because your viral load is presumed to be high and you are in labor. We don't have time to talk about long life ARVs at that point in time, right? And then the lifelong ART, whatever appropriate regimen for that mom, should then be started in the next 24 hours. So remember, once she has delivered and she's stable, we then start her on lifelong ART. And remember that the combination of tenofovir, lamivudine, and dolutegravir is our preferred regimen, right? And today we visited some hospitals and we realized that there is a phobia in delivery units, even during labor, to give TLD because we are scared that there will be neural tube defects. And we want to assure you today that there is no heavy, evidence. There is no absolute evidence confirming that the dolutegravir, mothers who take it will have very we will have very high cases of babies with abnormal, neural tubes. So we don't have that. We have a signal in Botswana, but in many other settings, studies have been done, and really we are not seeing it. Even here in Africa, we must have confidence. Dolutegravir at this point in time. However, we have to discuss the issue of contraception options as needed for our mothers. And let's educate them and ensure that we are able to help them in terms of adherence. So in terms of where we are, we said, one, make sure that obstetrically both the mother and the child are stable. Number two, assess women who need to be offered HIV testing in labor. Number three, assess whether all HIV positive women are on ART. Those who are on ART should continue as they have been taking. Those who are not on ART, we need to intervene by giving the state doses of tenofovir, lamivudine, dolutegravir, and nevirapine, and ensure that in the next 24 hours we provide education, adherence support, and prescribe appropriate regimens, as needed. So that is quite key when we talk about what must happen in labor. So this is again a summary to say at delivery and labor, if the mother is positive and on ART, she must continue her ARVs as prescribed. And then when she goes home, we want to give her at least a supply. She must have enough so that she doesn't run out of stock. 2 months of ARVs at that point in time. And then if we have a newly diagnosed or a known HIV positive mother not on ART, we provide single dose nevirapine with a step dose TLD, which is tenofovir, lamivudine, and dolutegravir. And then as soon as she's stable, we can discuss her lifelong, ART needs, and then we take it from there, right? Now, we spoke about HIV testing, we spoke about ARVs in labor. Another key important thing is now viral load monitoring, right? So it's very important that in labor, a viral load, firstly, we check if previously was there any viral load done, as is the case with our case, Leah. She had a viral load that was done twice antenatally. Both viral loads were high, but our interest is with viral loads that were done in the last 12 weeks, right? If that viral load was suppressed, so if in the last 3 months a patient had a suppressed viral load, we classify them as low risk. If in the last 12 weeks, the viral load was more than 1,000, we classify them as high risk. If we do not have a viral load in the last 12 weeks that was done, we would still classify them as high risk. This is very important. I know it's not written outright, but let's read in between what is being said by this third bullet. This third bullet means any woman who's on ART, who presents in labor, and you do not have a recent viral load, we classify them as high risk, right? And we have therefore to intervene when the child is born as a high risk mother-baby pair, right? And then all women must have a viral load test done at the time of delivery, right? So immediately after, if you can do it during labor, if she's still stable and not yet in pain, you can do a viral load. If you're doing other blood tests to confirm other things, you somehow do a viral load. Otherwise, if it's an emergency situation, immediately when she's stable or immediately after delivery, you do that viral load. So a delivery viral load, I usually confuse it and say a birth viral load. It's fine. But during birthing or a delivery viral load must be done for all HIV positive women who are on ARVs, right? We need to do that viral load, right? Although this viral load, we won't get the results immediately. However, we need to ensure that the barcode. So when you submit the specimen, there's a barcode on the form. You take that, you also put it on the road to health booklet so that when the mother goes for her follow-up at the local clinic, they're able to trace that viral load result, right? So very key, low risk, high risk. Who's a low risk mother? Where the viral load is suppressed. Who's a high risk mother? Where the viral load is known to be high or where we don't have any recent viral load. And recent is defined by 12 weeks. And that is quite key. And this is the schedule for viral load monitoring, right? Which has there's the antenatal component in terms of how we monitor viral loads. There's the delivery component, and there's the postnatal component in terms of that. And you would see that we have three kinds of women. We've got those who are newly diagnosed and initiated on ARVs for the first time during the current pregnancy. So we will start them on ARVs, and then 3 months, like you saw with our case, Leah, she was diagnosed for the first time antenatally. She was started on ARVs. 3 months down the line, we did a viral load, if you remember, which was high, and we needed to repeat it again in a month. And unfortunately, she still had, a viral load, and we needed to manage that. But what you see here is that anyone who's diagnosed antenatally, we start on ARVs, we do a 3 months viral load, but all women, right, will get a delivery viral loads, right? That's very important. They will get a delivery test. So there's a 3 months viral load, there is a delivery viral load, and there is a 6 months viral load postpartum or during the postnatal process, right? So very, very important, 3 viral loads. And then some women come in already on ART. So she comes in antenatal. She says, well, I know my status. I am positive. I'm on ARVs. So how do we approach this woman? At that diagnosis of pregnancy, at that first visit, we do a viral load. If it is suppressed, the next viral load will be a delivery viral load. And then again at 6 months postpartum, right? And you can see here, a woman who presents very late, she presents for the first time in the 3rd trimester. We won't do any viral load. We will start her on ARVs, but her first viral load will be the delivery viral load, right? And then there's now a recommendation to say we have an option to do, so depending which one comes first. Remember, if she's in the second towards the 3rd trimester and she reaches, her, she reaches 3 months on ART before delivery, we might still need to do, that 12 weeks viral load when she's on ART. But most of them, if she starts very late in the 3rd trimester, let's say she starts 1 month or even 2 months before delivery date, she will then get the delivery viral load and probably a 6 months viral load, depending on the results of that specific viral load. So that is very key. And I will share with you the guidelines, the updated PMTCT guidelines, which cover most of these algorithms. Now, there is another issue, right? Because remember, pregnant women, their process for viral loads is not the same as that of adults who are not pregnant. So when you order specimens for viral load in pregnancy, the lab needs to be able to identify these specific women as pregnant and specifically as part of the PMTCT program. So there are codes. So if you look at this form, which I will also show you later when we are done, maybe let me start this side to say that viral load testing, which is done in pregnancy, but also during breastfeeding, requires authorization, right? And this is done through specific codes that you need to put in on the form, right? As you submit the specific specimen. So for a viral load that is done during pregnancy, antenatally, and during breastfeeding, your code that you use is C#PMTCT. So you would complete, the patient details and tick the viral load and say which viral load are you doing. This is for pregnancy, as you can see there. And then you will come and put in the facility details and your own personal details as a health worker. But there they say, what is the EGK code? So it's C#PMTCT. That means it's either an antenatal or a postnatal breastfeeding viral load. If it is a delivery viral load, you need to put in C#delivery, right? So, and you will see here, we are saying if your form has a space like this specific, this is the new form, it has a space for the code, you would then put in the code there next to this star where it says EGK code, you will then put in the code there. However, if your form does not have the space for the code, you would then just put it next to the address. As you can see there, next to the address, you then put the code in. But over time, all the old forms will be phased out. We will then be using the new form, which has a specific space where you need to put in the code. If you do not put in the code, your specimen would be rejected, right? Because we are putting in the codes to ensure that the gatekeeping mechanism can accept your viral load to say, well, this viral load is not as per the normal pathway. This is for pregnancy. Therefore, let's allow this viral load to be processed. But it also helps us at the program level to be able to monitor whether all women who are HIV positive and on ART are actually receiving delivery viral loads. That's why for delivery, you would then use a different code, which is C#delivery, and then your specimen would not be rejected. So that is very crucial, right? So remember, viral load monitoring during delivery is very crucial, and it tells us whether we are dealing with a low risk or high risk mother baby pair, so that we are able to intervene appropriately. We dealt with this algorithm last week. It's just a reminder to you to say, please remember that if a mother has a high viral load, which is detectable, we need to address it through enhanced adherence, looking at drugs, whether she's a substance abuser, support at home, disclosure, assessing her for opportunistic infections, whether she's taking the drugs correctly, any other drug that she's taking that might make the ARVs not to work. And then if the viral load continues to be more than 1,000, after adherence, we should then consider switching her, to to a regimen that is working. So let's not just say, no, it's high, we will deal with the baby. No, we need to keep the mother alive. So if she has a high viral load, we need to manage that viral load as soon as possible on that note. So again, we spoke about the importance of HIV testing in labor. That was number one. We spoke about why we need to assess women who are on ART and those who are not on ART. We spoke about the importance of monitoring the viral load even in labor and delivery, and ensuring that a delivery viral load is done and we use the correct code. But women also come in with opportunistic infections. I mean, we know of maternal deaths from cryptococcal meningitis, PCP pneumonia, or even TB, which is quite common. So it's very important that even when a woman presents in labor, that we screen them for opportunistic infections. If they do have, we need to make sure that they get treatment. If they do not have, we therefore need to offer prophylaxis so that they do not get, these opportunistic infections, right? So if you look at delivery will be considered a follow-up visit, right? And then we would be assessing to say, if she's HIV positive and she's already on prophylaxis therapy, ours is to assess whether she's adherent, is she coping with the ARVs, is she coping with TB preventative therapy that she's on, is she coping with her cotrimoxazole prophylaxis therapy, and others would even be on fluconazole prophylaxis therapy. We assess for side effects and symptoms, and then we manage them, as needed. However, if she presents in labor and delivery, right, and we have screened her, for TB symptoms, and we find that she does not have symptoms, we need to assess whether she is eligible for TB preventative therapy, or not. And which is why here we are saying that all pregnant women with a new HIV diagnosis, or all those who are known to be HIV positive, right? But they are now pregnant. So even if, she's not a new HIV diagnosis, but she's HIV positive and now it's a new pregnancy diagnosis, we need to assess them and screen them for TB, right? And assess them and ensure that if they do have TB, right, we provide them with treatment. And then screening for TB in pregnancy requires two things. Number one is the symptoms. Are you coughing? Do you have night sweats? Are you having loss of weight? Those kind of symptoms. But in addition to that, we need to do a TB gene expert in all women, right? So even if it's in labor, before we discharge her, if she was not screened before, we have to screen her for TB, because we know even in the postnatal phase, some women get TB. And if the gene expert is negative, but she's got symptoms, she needs to be investigated further. If the gene expert is positive, we would then need to start her on TB treatment. The part that I want you to pay attention on, it is this bluish, I don't know if this is green or gray, I don't know, you'll tell me, but this area here, to say you have a woman who comes in, you have screened her for symptoms, right? You did the gene expert, it's also negative. Now you need to assess immediately post after she has given birth to say, are we starting her on ART? If she's already on ART, what is her CD4 count, right? If her CD4 count is 350 or less than 350, she qualifies for what we call TB preventative therapy. Why? Because she's pregnant, she's HIV positive, she does not have symptoms, and her gene expert is negative. If her CD4 count is very high, we can only start TB preventative therapy 6 weeks after delivery. So these are very, key issues to say. If she's got a high CD4 count, we can defer and start TB preventative therapy later. But if she's immunocompromised significantly, we need to ensure that she started on TB preventative therapy as soon as it is possible, as soon as it is possible or viable. So don't forget that in addition to testing for HIV, reviewing ARVs, monitoring the viral load, we need to also ensure that we are able to screen and treat for opportunistic infections. This TB preventative therapy, we mean INH prophylaxis, 300 milligrams per oz daily, together with pyridoxine for 12 months. So those are the key things. And there's other things we need to do for the mother. For example, we need to care for the mothers living with HIV and AIDS, avoiding traumatic and necessary procedures, like episiotomies, assisted deliveries, because these procedures, they can facilitate the mixing of the maternal blood, which might have a high viral load, with the infant. And we must avoid unnecessary suctioning. A cesarean section only if indicated, right? A cesarean section only if indicated for obstetric reasons, right? And as soon as delivery, we want to encourage skin-to-skin contact, because we are breastfeeding advocates. I am a breastfeeding advocate, and ensure that as part of the discharge process, she is given a safe conception advice, including contraception. She's got enough ARV drugs, and then she's got a clear appointment in terms of where she would do her 6 days appointment. So again, in terms of delivery, avoid these traumatic, procedures. Cesarean section only if indicated, and if they're going for a Caesar and they are not on ARVs, we still give them single dose nevirapine and TLD before they go, together with prophylactic antibiotics. So those are very key. So this is just to remind you to say, remember to avoid all the unnecessary procedures. And also, HIV positive women tend to have a very eventful puerperium. So immediately after delivery, we need to ensure that the HIV positive women have appropriate antibiotics for at least 2 days as such. And then if they do come back and they are not well with high temperatures, but they are stable in terms of their heart rate, they can get oral antibiotics. And then if we are dealing with an HIV positive mom who's not getting better on oral antibiotics, we then treat it as severe, right? And when we say severe, it means she has to be admitted and she has to get, IV antibiotics. This is so important. I don't know how to overemphasize it. An HIV positive lady with a high temperature, you have given antibiotics for 2 days, the temperature is not dropping. She probably has something else. You need to investigate and check whether it's TB or something else. And at that point in time, because she has not responded to your oral, she needs to be admitted. Please don't send them home when they are unstable. That is what is causing us, a lot of problems. If she's not improving on IV antibiotics, you need to look for PCP. You need to look for TB, cryptococcal meningitis. That is key, and this is just a checklist, which should be done for all pregnant women, to say, before you discharge them, are the vitals normal? Why are you sending a woman with a high BP home? Why? Why are you sending her home when she's not passing urine, or when she's got pain, low abdominal pain, she still has significant bleeding, she's got fever, she can't breastfeed, the breasts are engorged, she's dizzy, she's telling you I'm dizzy, you're like, no, Tina, they must go home. It's not acceptable to do that. And we need to ensure that they have adequate conception advice, but also the devices. We now recommend the long-term ones, especially IUCDs, as an option. And then we ensure that that follow-up visit is scheduled for this mother. Please don't forget this slide. This is the slide that if we do not pay attention to, we have women dying at home, which is generally, unnecessary. So please make sure, that we treat our women, in a holistic manner. The care for the HIV exposed infant. So key 2 things, basically here. All HIV exposed infants must get a birth PCR, standard, right? No arguments. The another one, all HIV exposed infants must receive some form of prophylaxis, right? If it's low risk, if they are born from a mother who had a suppressed viral load in the last 12 weeks, we may consider treating them as low risk and then giving them nevirapine prophylaxis for 6 weeks. However, the majority of our patients might not have that viral load. It would have been done in the first trimester, right? And the fact that we do not have a recent delivery viral load, we therefore treat them as high risk infants, where the infant must receive a combination of nevirapine and zidovudine. Nevirapine for 12 weeks and then AZT for 6 weeks. So just remember, low risk, high risk. Low risk is where we have a recent viral load in the last 12 weeks, which is suppressed, nevirapine only for 6 weeks. High risk, they would get zidovudine for 6 weeks with nevirapine for 12 weeks. So that is very, very, very crucial. And then ensure that they get appropriate immunizations and TB screening as needed based on the mother's approach. And then we must link, it must be an effort. We must take an effort to link every single mother-baby pair to a receiving facility and ensure that the referral documents are written clearly and that the barcodes for the results are documented in the Road to Health booklet or maternity card, so that the receiving facility at 6 days or even 6 weeks as needed, they are able to trace the results, and we ensure that we act on all those results. PMTCT is changing. Actually, the new guideline, and I'll show you the cover, it's no longer, it's not about prevention of HIV. It's a prevention of mother-to-child infections. It's not HIV, infections. All infections, hepatitis B, syphilis, COVID. Remember, if a mother has COVID and she gives birth, there's a chance that she might infect the newborn child. Therefore, the child needs to be screened, right? So we are shifting from prevention of mother-to-child HIV transmission. We are now talking about prevention of mother-to-child infections. Which ones? All infections that we need to check at that point in time. Now, in summarizing, Leah, who was seen antenatally, she was started on ARVs very early, you know, during her 3 months visit after starting ARVs, her viral load was 9,000. She was supported for a month, and then it was repeated 3 months, but we never saw her again, except now in delivery. What do you want to do with Leah? Yes, if she's got any emergency obstetric, any emergency obstetric issues, you want to first deal with that. If she's got the antepartum hemorrhage, we deal with that. HIV testing, she's tested, it's sorted, right? ARVs, she's on ARVs, it's a tick, she continues with her ARVs. Number 2, the issue now is that the last viral load was high. So what do we do? Yes, today we do another delivery viral load, because if she's been taking ARVs, we want to see what it is. But she is a high-risk mother-baby pair. So what do? We want to avoid unnecessary procedures. We want to minimize, you know, the mixing of the mother's fluids with the child's fluids. You know, as soon as the child is born, we classify the child as high risk. We start the child on nevirapine and zidovudine. We do a birth a PCR. We do a delivery viral load. We counsel the mother. And if her viral load is not getting suppressed, we need to switch her to second line, you know, and ensure that the adherence and support and breastfeeding, the whole package. And then we arrange her follow-up either at the same hospital, she seems to be high risk, this one, or at the local clinic with the barcodes on the different charts. You know, that would be appropriate management at a high level of this matter. I'm sure you'll have questions about it. In closing, just another quick case to say, abandoned babies, their mothers generally might not even deliver at the hospital. So she might be delivered somewhere, and the baby, like this one, Tepo, 1-day-old Tepo, is brought to you for testing. He's underweight already on day 1. The child is not ill. The mother, we don't know where the mother is, you know? So what do you do, abandoned baby? This is important because the algorithm has been updated, and this is my last slide for tonight. Pay attention that abandoned infant with unknown HIV exposure. So like here, the Tepo is abandoned. We don't know where the mother is, right? We must treat the infant as high risk. So when you get these babies, you must check their temperature, check their sugar, feed the baby, ensure that the baby is alive. If it needs oxygen, give the baby oxygen. Whatever the baby needs, you give them. But when it comes to HIV, you say, well, this child we treat as exposed because we don't know where the mother is. The child is high risk. When you see high risk, you know you have to start nevirapine and zidovudine, right? Both of these for 6 weeks because the child is not being breastfed, the mother is not there, and you perform both a rapid test and an HIV PCR, right? You do this test. This is because a positive HIV rapid test tells us that the mother is exposed, right? But it doesn't tell us what is the HIV status of the child. However, if the rapid test is negative, again, the child might still be in some, might have received low doses of the HIV from the mother and so on. So an HIV rapid test is no longer reliable, right? We are now also wanting to do a PCR, which will get the results later. Obviously, the rapid test results are there. But in essence, if you have an abandoned baby, you do two things. You test the child with a PCR and a rapid test. You give the child high-risk prophylaxis. If the PCR test comes back positive, obviously, we think that the child might be infected. We start the child on ART and confirm with a second PCR. If the PCR comes back negative, we continue the prophylaxis and we will do a 10 weeks when the child is 10 weeks old, we'll repeat the PCR. If that PCR is positive, the child needs ARVs. If it's negative, I think we are dealing with a child who is negative because now we have 2 negative PCRs, especially if the child is not being breastfed. We kind of like think the child is negative. Right. We could go for another hour teaching on PMTCT. It's not always easy. That's why we are dealing with it in bits and pieces. Antenatal, intrapartum, you know, and then we're going to do it the postnatal phase again next week. And that is very key. Right. So I'm going to, let's do this, few seconds. Thank you.